This presentation is about hand injuries. So treatment general principles for stable fractures, it can be treated by buddy tapping or splinting for around 3 weeks. Unstable fractures can be reduced and converted to stable position and immobilized in a cast. If the unstable fractures cannot be reduced, then it can be treated with closed reduction or open reduction and internal fixation with K-wire, tension band technique, screws or plate and screws. Then fractures with segmental bone loss, the primary treatment should be directed to the soft tissues, maintaining length with K-wire or external fixation. This may require secondary procedures like bone grafting. Then general indications for surgery include open fractures, unstable fractures, irreducible fractures, multiple fractures, those with bone loss or tendon lacerations. Open fractures can be classified according to Swanson et al. Type 1 is clean wound without significant contamination or delay in treatment and no systemic illness. Type 2 has one or more of the following: contamination with gross dirt, debris, human or animal bite, river injury, barnyard injury, delay in treatment for more than 24 hours, or significant systemic illnesses such as diabetes, hypertension, etc. So it can be treated with primary internal fixation in both the types. Primary wound closure is appropriate for type 1 and delayed closure is appropriate for type 2 injuries. So coming to metacarpal fractures, metacarpal can be divided into head, shaft and base. Metacarpal head fracture, if it is stable, can be splinted in protected position. Here the MCP joint flexion is more than 70 degrees to minimize the joint stiffness. The collateral ligaments of the MCP joint are relaxed in extension, permitting lateral motion, but they become taut when the joint is fully flexed, hence achieving more rigid immobilization. Hence it must always be immobilized in protected position. It is also called as position of safe immobilization or POSI. Displaced metacarpal head fractures can be treated with open reduction and internal fixation with K-wire or headless compression screw. So following immobilization of around 3 weeks, early range of motion is essential. Metacarpal neck fracture can be reduced by using the digit to control the distal fragment, but the proximal IP joint should be extended. Following reduction, it must be splinted in position of safe immobilization. Unstable fractures can be stabilized with K-wire. So boxer's fracture is nothing but fifth metacarpal neck fracture. So metacarpal shaft fractures, non-displaced or minimally displaced, can be immobilized in protected position. Displaced fractures may require open reduction or closed reduction and internal fixation with K-wire, interfragmentary screws or plates and screws. Metacarpal base fractures may be associated with carpometacarpal fracture dislocation. So additional true lateral and